Okay, so this video is about suicide. And we'll start off on page 41 in your course pack, myths versus reality. So there are often things that you hear about suicide that are not true. Um, Women do attempt suicide more often, but men do tend to complete more often, meaning that they have a completed suicide. That is because they tend to choose more lethal methods. Also, um, sometimes people think that if you talk about suicide that you're kind of putting that into the person's head, and that's not true. Patients need to talk about suicide. They need to talk about what their current thoughts are. So please don't hesitate to not only assess your patient, which we have to do, but also discuss their feelings regarding it. Now, when we talk about suicidal thoughts and behaviors, there are some different terms and things. And do keep in mind that one of the national patient safety goals is to help prevent suicide, because unfortunately it does happen in really any hospitalized patient, or it can happen. So, suicide is the act of intentionally ending one's life and opting for non existence. So, that's the textbook definition of it. A suicide attempt is an actual life threatening attempt, meaning that if there were no interventions, that it would either result in a suicide completion, or the patient thought that it would result in a suicide completion. Suicidal ideations are just the thoughts of hurting self, the thoughts of committing suicide. Suicidal ideations, as I mentioned before, do not necessarily need to have any intention. They don't really even need to have a plan. Parasuicidal behaviors are um, kind of the catch-all. So it's a newer term that they're using, and it has to do with suicidal, what we used to call like a suicidal gesture, in which the patient knows that they're not going to die, but more of like a cry for help, or um, just a way to let people know that it's very serious. But the patient, is a non-lethal type of attempt. No, I shouldn't say attempt. It's a non-lethal gesture. This also does include things like cutting. Cutting is usually done for very different reasons. It's usually in order to feel something. Patients will say that they're numb and that they want to feel something. So the pain is something that they can feel versus anything emotional. And no matter what, we take any ideations, gestures, anything like that, we take everything seriously. We take that suicidal or parasuicidal behavior seriously, and make sure that we directly assess suicide and suicide risk through questioning. So risk factors for suicide are things like feeling hopeless and helpless, worthless, not being able to problem solve well, very emotionally troubled lives, not having a high threshold for emotional pain, impulsivity, which we've mentioned about before, extreme solutions. They do tend to cluster in families. So, if somebody does commit suicide in a family, then it kind of opens the door for something that might have otherwise been taboo. Genes and problem solving in families. So there's genetic predispositions, of course, to depression, which is a precursor for a lot of suicide, not all. And the way that people problem solve in their family is then learned. Depression, alcohol, drugs, chronic physical illness, medications with side effects of depression. So if the patient takes the medication and they suddenly have depression and they've never had depression before, then that can be very difficult to cope with. So medications with a side effect of depression are another risk factor. Schizophrenia, unfortunately, it's a very high risk factor with schizophrenia. Borderline or antisocial personality disorders, which we'll talk about later in the course, panic disorder, and then incarceration. Cultural considerations. So there are certain groups often groups that are kind of sequestered a little bit. So Native Americans, Alaskan Natives tend to have a higher rate of suicide than others. There's also some protective factors when we talk about kind of cultural considerations. Religion is one that is often a protective factor. Antidepressants, we talked a little bit about this before. So unfortunately, suicide rates are increasing in adolescents and young adults. So we do need to be watchful in that. But antidepressants do actually help decrease the completion rate of suicide. So when we look at nursing process now, of course, we start with our assessment. And one of the first things that we should be doing is our self-assessment. So even before we go and we assess the patient, we want to make sure that we're assessing ourselves. It can sometimes be irritating. I've seen nurses be irritated with people who attempt suicide because they feel like it's just attention-seeking behavior, or they're anxious about working with patients who have tried to commit suicide, or they're in denial of how difficult that it can be to work with patients that are suicidal. There's a scale in your textbook. It's called the Sad Person Scale. And so this can be used for assessment, again, likely before the patient would come onto a psychiatric unit, actually to see if they need to be hospitalized. So it looks at gender, age, depression, previous attempts, substance use, their thought process, their socialization, their plan, things like not having a spouse, illness, stuff like that. So it is a scale that can be used to determine if somebody should be hospitalized. The couple of things here, your textbook talks about overt and covert signs. I don't 100% agree with the way that they have these categorized, but you should have an idea of what an overt sign first, which means that it's very it's easy to tell that this patient is suicidal based on what they say. So things like, I can't take it anymore, life isn't worth living anymore, I wish I were dead, everyone would be better off if I were dead. Those are all potentially suicidal type statements. Then there are covert statements, which I think a couple of them seem a little bit more overt to me, but I guess it would depend on how they were given in context too. It's okay now, everything will be fine. Things will never work out. I won't be a problem much longer. Nothing feels good to me anymore and probably never will. How could I give my body to medical science? Behavioral clues we mentioned before, giving away those possessions, farewell notes, having a will, affairs in order, insomnia, unexpected improvement, neglecting hygiene. So I know we already discussed those. And then we need to look at the lethality of the plan. How detailed is the plan? How lethal is the proposed method? So we're really looking to see how quickly would that person die if there was no intervention. Can you actually stop it? So things like guns, hanging, carbon monoxide, car crashes where somebody runs into something like a semi-truck or something else, versus less lethal methods like pills or cutting the wrists. Do they have the availability of the means? Do they have those means, or is it not readily accessible? Is it something that they would still need to work on getting? So assessment guidelines, we do want to ask those questions. And there are some questions here that we can ask, are you thinking of harming or killing yourself? But we really use that Columbia scale, which you guys are going to trial using next week. So we want to make sure that we're assessing not only risk factors, but protective factors as well. We want to know if there's a history of suicide attempts, because that obviously makes it more likely that they might try it again. So those red flags, just to add a couple to it, we talked about being sad and depressed and quickly happy and peaceful because they made that decision to end their life. Also the treasured possessions, giving those away. But a couple more that we haven't discussed yet would be psychosis. So if your patient is psychotic, that can be definitely a red flag for suicide, as well as if they're having command hallucinations. So command hallucinations would be usually voices telling them what to do, and if they're telling them to hurt themselves, it's difficult to imagine that, but having voices in your head telling you that you need to kill yourself, that you're worthless, that you'd be better off dead, that you need to kill yourself, I mean, just over and over, that's definitely a big risk factor for suicide. Excuse me. You also want to assess the social supports and any medications that the patient is on. So diagnosis, risk for suicide would be the main one, although there's probably other ones that could also go along with it depending on the symptoms that the patient has. Outcomes and planning. So we always want to explore alternatives with the patient to help them with problem solving, because right now they're believing that there aren't any other ways to solve their problems at this point in time. So we want to try to help them with their problem solving, help them increase their coping skills and decrease their isolation. Implementation, um, we want to watch their safety, their medications, we want to administer those, again, help with problem solving, ensure that they have support, and then utilize any religious or cultural beliefs that they may have that may be protective. Communication guidelines. So some things that we want to ensure that the patient understands is that crisis is temporary. We'll talk about crisis in the next week or so. And crisis by definition can't last forever. So crisis is temporary. Unbearable pain can be survived. They can do this. Help is available, and we're that help. So we are available to them. And when they are done, we're going to make sure, when they are discharged from the hospital, we're going to make sure that they continue to have help and they're not alone. They're not alone now, and they won't be alone in it when they leave. Interventions during the crisis. We want to make sure that we follow our protocols and we keep thorough records of things if the patient does try to attempt, whether on a psychiatric unit or if they're in, active crisis mode because they're still trying to attempt while they're there. They likely may be on a one-to-one observation, which means that a staff member must stay within arm's reach at all time. Or they could be on what we call a line of sight, where a staff member has to be able to see them at all times, which at night turns into a one-to-one because they go into their room. We also use no suicide contracts now. There's new research on that these may not be very effective, but currently in practice, they're still used. So it's really where we ask the patient, a lot of times they're verbal, although outpatient, they might be written, that if they felt like they were going to act upon any of their thoughts, that they come let a staff member know. And so they might call that a no harm contract. Problem solving, we're going to help them with problem solving and then do our 15-minute checks on them and on their environment. Interventions after a crisis. So if somebody does attempt, we're going to stay with that person, remove any weapons or pills or whatever means they were using. We're going to talk to them about alternatives at that point. We don't want them to make any major decisions, though. So anytime somebody has been in a crisis, it's not the time for them to make major decisions. And then they would also have community support, and we would make sure we set them up with that. They should not go home with more than a 1 to 3 day supply of medications, just because we don't want them to overdose again. Now, if somebody has a completed suicide, then we do what's called a postvention, which is 24 to 72 hours after the death, in which the family is contacted and things are discussed with them. What we need to let the family know during that time is that they may feel stigmatized, and that's normal. It's also normal to be angry and that they're not going quote unquote crazy. that those are normal reactions. It's okay to be angry at that person for what they chose to do. We help them with outlets, so we make sure that they have a way, like a self-help group, therapy, things like that. We make sure that they're linked up with someone. So if a suicide actually happened on a hospitalized patient, then that is a sentinel event. And so there's a big investigation and things that would happen. Of course, we do everything in our power to keep that from happening. But if it were to happen, you'd have to follow protocol, and it would have to be reported, of course, internally, and that would be a sentinel event workup. They would also do a psychological postmortem assessment, which means they would be looking at everything that happened and all the people that were involved. So the rest of this is a case study, and I would like you to take a look at this case study, read through it, and then come up for the as evidenced by on page 45 under the different nursing diagnoses. Before we go, I just want to share with you that some of the things I've learned with working with patients who are suicidal. So I have, unfortunately, early in my career, I worked with a patient multiple times, young patient, very, very ill individual. And she worked with her multiple times. She'd come in, she'd get discharged. Her family was very supportive, very caring. And, we ended up finding out one day that she laid across the railroad tracks. It's very difficult to process sometimes, but what I had to understand, and I'll tell you one more story about it too, is that I can't control other people's behaviors. All I can do is my best to try to help that person while they're there in the hospital and try to give them the tools that they need in order to go home and be healthy and safe. And sometimes patients, no matter what you do, they've made up their mind and they find a way. So the other patient that sticks out in my mind had a probably middle-aged gentleman, and I was very early in my nursing career, and I was sitting down with him. I had just gotten a report, so I was really just kind of assessing him, talking to him, and I had to transfer him down to our geriatric unit. So maybe he was in his 50s or so. And I remember just talking to him, and I, asked him kind of the assessment questions. Are you having any thoughts of hurting yourself? And he answered, no. And I asked him about his attempt, what brought him into the hospital. And, he said that he had tried to overdose on pills and that he was very surprised when he woke up. The information I got in the report is that this gentleman had everything that you could think of all figured out. He had emailed family members saying goodbye. He had someone taking care of his dog. He had, I think, even paid for his funeral, but he had picked out the clothes that he wanted to be buried in. Said goodbye to everybody. I mean, he had things squared away, and he took pills and did not expect to wake up at all. And I remember talking to him, and he's saying all the right things. He's saying, that was the biggest mistake, and my family was so upset. I could never do this to them. It was the biggest mistake I've ever made. And he's saying the things, and I have to document what he says. And just in my stomach, he gave me a stomach ache is actually what happened. And I just felt really unsure about him. So I gave a report, and I told the nurse that was giving a report to that, he's saying all the right things, but he just keep an eye on him. He makes me really uncomfortable. And so I remember, he got transferred. He was there for a few more days, and then he got discharged home. And within 24 hours, the next day, he was in the newspaper that he had he had committed suicide. So unfortunately, sometimes when patients really want that to happen, they do find a way to do it. And so what I recommend is that you have to learn not to take it personally and not as a failure, but that as a nurse, you're doing what you can, and patients make their own choices. So um, from here, what I would like you to do is to go ahead and finish those case studies, and I'm not sure if I'll post a short video going over them or just post the answers that I have, but either way, you'll have those soon. And look forward to for your virtual clinical over the next couple days. Thanks.